Hey Medgeekers, Caitlin here, and for this week's episode, I want to talk about how to dispo patients in the emergency department. The emergency department is a place where we figure out where patients need to go after initial resuscitative measures, of course. So, how sick are they? Should they be discharged, admitted? Is the patient going to emergency surgery? So, today I want to talk about certain tricks of the trade that will help you dispo patients that are in that gray area between discharge and being admitted. So, the certain things I want to cover today are the walk test, the PO challenge, and Curb 65. All tests or calculations that help you dispo patients in that gray area. So first let's talk about the walk test. This is simply monitoring the patient's O2 while they ambulate. I like to use this for COPD and congestive heart failure exacerbations. So in these exacerbations, these patients will come to the emergency department with a new oxygen requirement. So measuring their oxygen requirement while they ambulate or even at rest can measure how or where they are going to go and dispo the patient, whether they can be discharged or admitted. So let's talk about COPD exacerbations really quickly. So these patients will come in with that increased oxygen requirement I talked about before, an increased cough or increased sputum production, or just the chief complaint of shortness of breath. And the initial resuscitative measures on these patients usually include a breathing treatment, so ipratropium and albuterol duo nebs, systemic glucocorticosteroids, supplemental oxygen, and even getting them started on some antibiotics. And then you need to go and reassess these patients after you do your initial resuscitative measures. So, are they still wheezing? Are they still short of breath? What's their oxygen requirement now? These are all the things you need to ask about if this patient's going to be discharged or admitted and how they are progressing with their initial treatment. So, if all of that is not improved, then it's not unreasonable to consider admission for this patient for further treatment. But if they are improved, then you can apply the walk test to see if they desat on their home oxygen while they ambulate. And if they do, then that is means for admission as well. So let's do a scenario with congestive heart failure exacerbations. So these patients will come in with the chief complaint of increased shortness of breath, especially while lying flat. They might have that paroxysmal nocturnal dyspnea. They may have an increase in that lower extremity edema. And the initial resuscitative measures for these patients are IV Lasix, so just getting a lot of the fluid off their lungs. And then plus or minus hypertension medicine, and this usually includes nitroglycerin, which is really good at getting fluid off the lungs, as well as morphine, and obviously that supplemental oxygen. So reassess these patients after all those initial resuscitative measures, and if they are not improved while they are just sitting in the bed, then that is means for admission. If they are improved with their oxygen requirement while sitting in the bed, do that walk test, see what happens when they ambulate, and see what their oxygen requirement is with that. And if that is not improved, then that is also means for admission. So next I want to talk about the PO challenge, and this is used in disease states that have a lot of associated nausea and vomiting. So PO means by mouth. So if patients cannot take in anything by mouth, i.e. their antibiotics, they need to be admitted for IV antibiotics. So a good example for this is pyelonephritis, which has usually a lot of associated nausea and vomiting. So if these patients have controlled their nausea and vomiting in the emergency department, you can test them with some oral fluids, some oral antibiotics, and if they tolerate that well, then they can be treated outpatient. But if they can't, then that is means for admission. But just keep in mind that you need to look at the overall picture of the patient. So if they are critically ill in any way, their vital signs aren't stable, they have very high fevers, or if they are immunocompromised in any way, even if they are tolerating PO, then they need to be admitted. So next I want to talk about Curb 65, and this is a fun little mnemonic that will help you dispo pneumonia patients. So with Curb 65, the C stands for confusion, so if the patient is confused at all, they get a point. The U stands for urea, so if BUN is greater than 20, they get a point. If their respiratory rate is greater than 30, they get a point. If their blood pressure is less than 90/60, they get a point. And if their age is greater than 65, they get a point. So 0 to 1 points, you can choose outpatient and or inpatient. 2 points, definitely inpatient. 3 to 5 points, inpatient, and consider ICU if it's 4 to 5. And that's it, guys. Thanks for listening. I hope this helped you dispo patients that are in the gray area for you in the emergency department. But just never forget about the gestalt you have as a provider. So, if any of your patients are immunocompromised in any way, usually admission is required, even if their CURB 65 score is low and they can maintain PO antibiotics. Um, Never forget about the overall picture of the patient. Alrighty, see you next week.